Welcome to this explainer. Today, we're doing something a little bit different and highly practical. Instead of just staring at abstract equations on a whiteboard, we're going to frame these seemingly dry physics concepts as a hands-on shift in a busy physiotherapy clinic. So consider this a crucial welcome to your clinical survival guide. We're going to bridge the gap between the textbook physics you study and the actual living patients you treat every single day. Okay, let's take a quick look at today's clinical syllabus. We'll start off with the bioconduction baseline, then we'll check out the shield for electrical safety. After that, we'll tap into the power of latent heat, apply it to wax versus cryotherapy, and finally, wrap things up with preventing therapy burns. Let's get right into it. All right, Section 1, the bioconduction baseline, where we'll focus directly on the patient's body. Imagine you have a full waiting room today. Your very first patient is a runner with a deep hamstring strain, and they really need some electrical stimulation. But before you even think about touching a dial on that machine, you have to look at their anatomy as a complex electrical circuit. Why does adipose tissue, fat, present such a massive, literal roadblock to getting that therapeutic current down into the injured muscle? Well, to answer that, we have to look closely at human biology. Current flows through the body in a fundamentally different way than it flows through the wiring in your clinic's walls. Your body conducts based on electrolyte concentration, specifically the movement of ions like sodium, potassium, and chloride, and of course, water content. It's not just free-flowing electrons like you'd find in a copper wire. And because it relies on this ionic movement, the tissue's temperature actually plays a huge role too. Higher temperatures will genuinely increase that conduction. And this is exactly why fat is such a tough hurdle. Muscle and blood have extremely high relative conductivity because they are just packed with water and ions. Nerve tissue is somewhere in the moderate range, but fat and bone, they have incredibly high impedance. They fiercely oppose that current flow. You absolutely have to understand these tissue layers to predict the depth of penetration for your electrical modalities. If your patient has a thicker layer of adipose tissue over that target hamstring, you've got to adjust your clinical approach, for sure. Actually, scratch that. The very first barrier you're going to encounter is the skin itself. If you've ever applied an electrode to a patient's dry skin, you've probably watched the electrotherapy machine just struggle and beep against incredibly high resistance. That's because dry skin is a strict insulator. It stops current dead in its tracks. So the crucial takeaway here is that conductive gel, or saline pad, isn't just some optional clinical accessory. It is your essential biological bridge. It provides the exact water and ion interface you need to bypass that skin resistance and safely deliver the treatment. Moving on to Section 2, the shield. Let's talk about insulation and electrical safety. Now that we've figured out the patient side of things, let's talk about protecting you and your equipment. While we really want high conductivity in the patient's muscle, we absolutely demand non-conductivity everywhere else. By definition, an insulator is a material with incredibly high electrical resistance that totally restricts the flow of electric current. Materials like rubber, plastic, wood, and glass lack those free electrons. They stop electron flow completely, serving as this essential, life-saving barrier between the raw electricity pumping out of the wall and fragile human tissue. Out on the clinic floor, these insulators are your literal armor. Think about the physical things you grab every single day. The plastic cable coating protecting the lead wires, the thick rubber safety shielding covering the metal parts of the machine, the insulated handles. Add to that your strict protocol of keeping the surroundings bone dry to prevent any rogue conduction through spilled water. This is exactly how your equipment protects both the therapist and the patient during every single treatment. And hey, regular maintenance isn't just boring administrative busy work. It's how you verify that your physical shield is actually intact. But there's a fascinating middle ground we have to mention here: semiconductors. While insulators protect you and conductors deliver the therapy to the patient, intermediate conductors, like silicon and germanium, are the actual brains inside your electrotherapy machine. They make up the transistors, the diodes, the rectifiers. They are the whole reason you can precisely dial in the specific waveform, frequency, and intensity that your patient desperately needs. They're the physical link between your clinical intent and the electrical output. All right, Section 3, the power of latent heat, covering the physics of thermotherapy. Okay, next patient up is an elderly individual dealing with some really severe chronic joint stiffness in their hands, so they need thermotherapy. To treat them effectively, we rely on a brilliant principle from Lehman, who noted that during the melting of wax or ice, the temperature remains constant, even though heat is being actively absorbed or released. Sounds totally counterintuitive, right? Heat is moving, but the thermometer isn't budging. But this is the exact literal mechanism behind why your hot and cold packs are so incredibly effective. We call this phenomenon latent heat. By definition, it's the heat absorbed or released during a change of physical state, like a solid melting into a liquid or a liquid boiling into a gas, without any accompanying change in temperature. I like to think of latent heat as a massive invisible storage bank for energy. This is the key physical concept you are harnessing during both thermotherapy and cryotherapy to actively manipulate a patient's tissue metabolism. Let's see this in action. Section 4, Clinical Application of Wax versus Cryotherapy. The contrast between these two therapies is basically physics at its finest. With paraffin wax therapy, you dip a patient's hand into molten wax, and as you pull it out, that liquid wax turns solid. As it solidifies, it releases its massive store of latent heat directly into the tissues, safely and slowly. On the flip side, with cryotherapy, the solid ice melts into a liquid, and to undergo that phase change, the melting ice has to actively absorb latent heat right out of the patient's body, which creates a really profound cooling effect. These are seriously powerful tools. Depending on whether your patient is presenting with acute inflammation or chronic stiffness, you are actively choosing whether to deposit stored heat into their tissues or drain heat out of them. Paraffin wax provides that uniform, prolonged warmth. Cryotherapy actively decreases local tissue metabolism to fight acute pain and swelling. Heck, even your standard hydrocolloid or hot packs rely on this, storing massive amounts of therapeutic heat through a water phase transition deep inside the pack. Which brings us to Section 5, and this is absolutely non-negotiable. The safety mandate, focused on preventing therapy burns. Look, mastering these properties isn't just about passing a physics exam. It is the literal difference between a highly successful treatment and causing a really severe injury. Because latent heat transfers so much raw energy, the risk of a thermal burn is incredibly real. So you have to follow the safety protocol. Step 1, you must always check the patient's baseline skin temperature and, most importantly, their sensation before applying anything. If they have nerve damage and can't feel the heat, they simply cannot tell you if it's burning them. Step 2, ensure adequate insulation layers, like specific towel wrapping to tightly control the rate of that latent heat transfer. And Step 3, strictly avoid excessive heat storage by following exact timing protocols. As we wrap up this explainer, I want to leave you with one final, kind of provocative thought for your clinical practice. You control the physics, sure, but how well do you actually know your patient's biology? We've learned today that your machines, your waxes, and your ice packs all rely on the pure, predictable laws of physics. But your ultimate success and the safety of the person sitting on your treatment table will always depend on how accurately you read the living human tissue, the water content, the ions, and the sensory nerves underneath. Keep that in mind on your next clinic shift. Keep studying, stay curious, and I'll see you in the next explainer.